This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
And welcome to the human side of healthcare. We're delighted you're with us today. We're going to have two special guests from UT Southwestern Medical Center and Texas Health Resources. And they're going to talk about a major study right here in North Texas that's designed to help the DFW area learn more about COVID-19. The aim is to make our communities safe, examine different aspects of COVID-19 to help us prepare for the future. We welcome to the show Dr. Jasmin Tiro, an associate professor of population and data sciences at UT Southwestern, and Dr. Andy Masica, chief medical officer for Reliable Health at Texas Health. Thank you both for being here today. And Andy, I think we'll start with you. Can you tell us a little bit about what this study is, what you're trying to find out, and really, ultimately, what can we all learn from this?
Certainly, Steve. And first off, thank you for giving us the opportunity to talk and discuss this study a bit further. So at a high level, what we're trying to do is generate additional information about the epidemiology of COVID in the DFW area and also gain a better understanding of the immune response to the disease. And importantly, we're trying to do that in a random sample of the population that represents the diversity of the DFW area. So some specific questions that we're going to try and answer. First, how many Dallas and Tarrant County residents are currently infected or have developed antibodies, which suggest infection in the past with COVID-19? We also want to look at what is the current and past prevalence. And when I say the word prevalence, what I'm talking about there is how common is a disease in a particular population. So what is the current and past prevalence for particular frontline and essential occupations? And these would be things like grocery store workers, potentially teachers, other employees in the community that are forward-facing and have contact with the public. Another question we're looking at is the degree to which prevalence estimates vary for different population segments across the DFW area. And then lastly, what is the duration of immune protection? So more specifically, what is the change in antibody status related to COVID-19? And how does that evolve over time as our policy shift and and things progressively open, such as schools, sporting events, things like that?
Dr. Tiro, what areas of North Texas will this COVID-19 study focus on?
So our study is recruiting participants in two ways. First, we have a household-based sample where we're inviting residents of Dallas County and Tarrant County to participate, 15,000 from each county, 30,000 total. We're also recruiting essential workers who work for essential businesses who have to not practice social distancing, come into their business and deliver services. And we are recruiting people who live all over but work in Dallas and Tarrant County in that essential business. And we're recruiting about 14,000 for that sample.
And so, Dr. Masica, as you look at the DFW area, in your mind, why is this project so important to us?
Well, I think the first thing to consider is that COVID is a community problem, and developing solutions for a community problem requires a community-based approach. So that has really been built into our study design. The second is that we read papers and we see news reports from across the world and across the U.S. This study is really going to give us to a very granular level what is happening in the DFW area. So, for instance, a research paper that was published about data in Spain isn't necessarily applicable to North Texas. And so we really want to have, in great detail, understand how common this disease is in the population, and that's going to allow us to inform interventions. The other aspect is that the information we're going to collect here is from a random sample of the population. Much of what we know about COVID and COVID testing and COVID positivity rates have been obtained from patients that either came in because they didn't feel well and they wanted to have a test, or they felt there might have been an exposure. So that the argument there is that that's a biased sample in terms of a lot of what we currently know. So this is a cross-sectional random sample of what's going on in the DFW area. And we think that is what makes our study unique in terms of its design.
Why is it so important that you get a variety of people across the DFW area?
So it's really important to note that Dallas and Tarrant County is a really diverse community of almost 5 million. And what we know from other studies conducted throughout the United States is that volunteer samples frequently obtain data on the worried well and may be biased in certain ways. We also know from national data that race-ethnic disparities are present in terms of those who test positive for COVID, those who are hospitalized as a result of an infection, and even those who have access to testing. And others have also hypothesized that occupational status, whether someone is an essential worker or has the option to remote work, as well as their income level, can affect their risk of COVID. Finally, we also have some data that suggests that people are confused or might be misinformed about how to stay safe, protect their families, and do social distancing. We need to gather local data on our population here in Dallas and Tarrant to understand how these various factors contribute to COVID infection in our community.
So I received this in the mail. Sell me, our listeners, on why I should participate and why should I get involved.
So, Steve, there's multiple aspects. The first is just from an individual level. If an individual chooses to participate, you then have knowledge if you are an active carrier of the disease. You'll also will have knowledge in terms of whether or not you were exposed to the disease in the past. So that's one piece of information you get directly from participating. The other is more of a broader societal and community benefit. So we've heard the general advice that we need to wear masks, we need to socially distance, and we need to wash our hands. Good advice, advice that is effective, but it's high level, and although there's sort of principles you can carry through, what we really want to try and understand is, are there specific areas that are hotspots for the disease that we need to intervene in? Are there specific behaviors that are higher risk than others, specific environments? And it's that more granular information that we think is going to contribute to the community's knowledge of our understanding of COVID-19, how we prevent its transmission, and really how we prepare to deal with its presence in our community for the foreseeable future.
You know, Thomas, fascinating discussion with Dr. Tiro and Andy Masica. In the foreseeable future, we are going to have to live and coexist with COVID-19.
I think that's why accumulating this data in the North Texas area specifically is going to be so beneficial, because there are things unique to any geographic area. I don't know if this is going on in other areas of the country, but boy, if we're taking the lead on this, pat on the back.
You're right about that. Hopefully we can learn, and that will help us in the future.
This is so important that Steve and I are going to unpack it more and have some discussion around it. Coming back next on the human side of healthcare.
This is the human side of healthcare on 1080 KRLD and the radio.com app, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
And welcome back to the human side of healthcare. Thomas, what a fascinating first segment. You know, it's good to see collaboration, this collaboration between UT Southwestern and Texas Health, but the information that they're going to find through this study, they're going to share. They're going to share in the DFW area. That's the beauty of how our hospital systems work together collaboratively to improve the health of the community. You know, we really have been after COVID-19 since March. I'm not saying we can take a breath and let our guard down. We've got to keep doing all the things we've been doing. But now it's time really to look at data and see if we can learn and have decisions based on data. This is one of the first steps, this survey that they're doing, this accumulation of data. And Thomas, this will have a ripple effect. As we learn more about COVID-19, it impacts material management and purchasing. It impacts staffing. Obviously, clinical treatment, modeling, all of the above comes out of good data research.
How would you imagine the data that we will get in North Texas could be different from data that might be collected in any other major metropolitan area in the country?
I think it could be a little different. I'll give you a great example. When COVID hit New York, it hit it really hard. But many people are packed on subways, on buses, and they are a very, very, very densely populated community. Even though we've got 7 million people here in North Texas, we're still a little spread out. So things we learn here from the data will may be unique to North Texas.
And Steve, if people didn't catch the first segment, we're talking to two professionals, one physician and one PhD. Well, she's very much into data, for sure. Right. But we're talking to two folks from UT Southwestern and Texas Health Resources about a collaborative survey of which about 30,000 are going to be delivered to residents of North Texas, select people to participate in a COVID study.
You're exactly right, and we're delighted that we've got Dr. Jasmin Tiro with us from UT Southwestern and Dr. Andy Masica from Texas Health Resources.
So we continue the interview now with Steve asking the first question about how these surveys are going to be delivered.
What should people be considering or looking for if they are selected to participate in this study?
So it's very rare nowadays that you conduct studies by mailing invitations to participants. But that's the best way for us to systematically invite people for this study. Most people think now that everything can be done either by cell phones or by email invitations. But we don't have a good systematic way of making sure we invite people from different parts of Dallas and Tarrant County unless we did a randomly selected household-based sample. This is how we're also others are conducting the census, and so we're using some of the same methods as the census is doing. What people have to do is look out for their mail, check their mail, and hopefully respond as quickly as possible so that we can get their data out and process it and provide information to our policymakers and businesses.
How soon do you think the mail-outs will go out for people to participate? And then once they participate, do you have any timeline as to the results?
The first wave of mailings went out about 2 weeks ago in Dallas County. We also have released the first round of mailings in Tarrant County. So if you live in one of the areas that has been identified for that wave of invitations, you should either be looking for something on your kitchen table or monitoring your mailbox for something that may come in soon. This study has been supported by a number of stakeholders across the community, government, philanthropic institutions, and other community partners. So we want to be very transparent with sharing the results. We believe we'll have enough participants where it makes sense to post the results. Probably by the end of September is when we'll have the first publicly reported information. And that's something else to note about the study in general. Most research takes months to years. Given the nature of what we're dealing with, the community support and engagement, we want to be very transparent in terms of what we can present to the public. We want this to be used for shaping policy, to inform individual behavior, and then also, as I mentioned, in collaboration with our business community, to help to give them information in terms of how to best operate their businesses safely for their workers and for the communities that they serve as well.
Dr. Tiro, this study obviously is looking at the Dallas-Fort Worth area. And I understand once you get the results and what you can glean from this study, we'll know it and you'll share it here in the DFW area. Do you think, though, that once this is completed, this information might add value to other parts of the country?
Absolutely. While we like to think that we're unique here in Dallas and Tarrant, we're actually have some of the similar factors in urban areas that might be affecting the spread of COVID and could be generalized to other areas. And I'm sure that there will be other urban communities that will want to reach out and understand our data and think about how it might inform their own practices and policies. And we will be very happy to share that information with all of them. But it will also benefit our own local community, and that's what I'm most excited about is how being thoughtful in how we gather and present our data to the lay public as well as government agencies and public health agencies as well as community organizations can help guide kind of their decision making and where they're deploying resources that benefits our community.
You know, we've focused on COVID-19, but as we know, cooler weather is on the way. And we have the threat of influenza. Currently in Tarrant County and Dallas County, many of the mosquitoes are testing positive for West Nile. For our listeners out there, what general advice can you give them?
So as a behavioral scientist, understanding how and why our public health agencies give us certain guidance is really important. And what they're saying right now is it's really important for you to practice social distancing and wearing masks. While we don't know how many people in DFW are currently infected and don't have any symptoms and may be passing on COVID infection unknowingly, we do know that these behaviors of wearing masks protects you and your close contacts. We also know that people don't have their normal routines to maintain their exercise, and so a lot of them are exercising outside, walking, etc. But with West Nile, we need to protect ourselves from mosquitoes. And so paying attention to your backyards, not having any standing water, and spraying yourself with mosquito spray is also important as you are outside and exercising. Finally, as flu season approaches, I would be remiss in not suggesting that you get your flu shot. We are really worried about what we call a twindemic of both COVID and influenza. And so influenza vaccine is very effective and can help minimize your symptoms if you do get infected. So do both and protect yourselves by washing your hands, getting your vaccine, and practicing social distancing. These are the only proven ways to limit community spread of these diseases, and it's really important that we pay attention to them.
That was a great discussion we just had, Thomas, and I hope the people out there that get this survey will fill it out and return it because they're going to be an integral part of helping us learn more about COVID-19 right here in North Texas.
That information will be so valuable in North Texas. And I've got to say, I think that if you get a survey, it's going to be pretty easy and that it will not be like brain surgery to fill it out. And Steve, in radio, that's what you call a segue.
What a segue, Thomas. I got to admit, you set me up pretty well. And for our listeners out there, we are going to talk a little bit about brain surgery. We're very fortunate to have with us Dr. Anthony Maioriello, and he's the assistant professor in the Department of Neurological Surgery at UT Southwestern, and he also does work in neurosurgery at Texas Health Dallas. And Thomas, thanks for setting me up.
Well, you know, this is one of those fascinating conversations because one of the things we're going to talk about are brain aneurysms. I don't know about you, Steve, but I've known a couple of people who were friends who died in their 40s of an aneurysm. It's one of those silent killers.
And Thomas, you're right. I've known people, unfortunately, that died suddenly from an aneurysm. And I'm sure our listeners out there have got people that were family or friends that have died of an aneurysm. This is a fascinating discussion coming up.
This is medical science on its most cutting edge. And Dr. Maioriello is going to give us really a story of hope, Steve, where he saved the life of one of his kids' sports coaches.
It's just amazing some of the technology and work that we're doing, especially in brain surgery today.
We'll be back with our interview with Dr. Anthony Maioriello coming up on the human side of healthcare here on 1080 KRLD
and radio.com.
The DFW Hospital Council, along with our over 90 member hospitals in North Texas, are proud to bring you the human side of healthcare with Council President and CEO Stephen Love and co-host Thomas Miller.
And welcome to the human side of healthcare. I'm Steve Love with the Hospital Council and Thomas Miller here with me today. And we're going to talk a little bit today about the brain and brain aneurysms. We couldn't have a better guest to be on our show today than Dr. Anthony Maioriello. And he is the Vice Chair of Neurosurgery at Texas Health Presbyterian Hospital in Dallas. And he is working with a new program. So let's begin with this question. Can you discuss the new neurosurgical program here in Dallas, which is called the UT Southwestern Neurosurgery at Texas Health Dallas?
So I've been at Presby Dallas for 4 years, and then I was invited to join the faculty at UT Southwestern. And so essentially it's a university-run program, but in a community hospital, trying to elevate the level of care at the hospital.
So as you look at this program, what would you say separates it from other programs maybe you've been involved with?
Yeah, so I've been in private practice for 16 years now, and now with being in a community hospital but with an academic affiliation, we're able to pool the resources that we have at the university and offer a wide spectrum of care for neurosurgical diseases. And we have also neurocritical care physicians at the hospital 24/7 also. So it's changed the hospital from just a community hospital to really one of quaternary care, where we're providing the leading cutting edge techniques in neurosurgery.
You know, you mentioned a great term there in your answer, quaternary care. Can you explain what that means?
It's kind of, the buck stops there. It's the highest level of care. So it's where your level 2 and even some level 1 trauma centers would normally refer out to a university setting where we take care of the highest acuity and the sickest patients. And we're able to do that with neurosurgery now that we have, full gamut of the subspecialties covered and having the neurocritical care piece at the hospital.
You know, Thomas, I know you know a lot about clinical, et cetera, but for this to be based in a community hospital is certainly something new.
Oh, absolutely. And what I was wondering is, turning the tables, what's the difference in this model versus seeing patients at the medical school facility?
That's a good question. So we're trying to emulate the same level of care where we work hand in hand with our partners at the university, utilizing the same protocols, same types of procedures. And the difference is we're in a community setting and you're mainly seeing the physician. So we don't have the medical students, we don't have the residents per se. Eventually we will have a resident rotate with us, but it's more your typical private practice setting, but with university level care.
And this program is located on the campus at Texas Health Presbyterian Hospital in Dallas. So you have several neurosurgeons that are on hand to handle complex cases. I'm not a clinician, but I know one of those such cases, a wide-necked bifurcation aneurysms. What exactly is that, and how do you treat it?
Yeah, so aneurysms are malformations of the blood vessels in the brain, and the wide neck is just describing a specific subset of that. And so there's a couple different things that we can do. I'm an endovascular neurosurgeon. I also do open vascular, which means I can operate on the brain by opening up the head, or I can operate on the blood vessels from the inside of the blood vessel. So I go up through the leg like you would for a cardiac cath, but instead of going to the heart, I go up into the brain. And I could put wires and certain devices in the blood vessels. We can retrieve clots for stroke. And for aneurysm specifically, there's a couple different devices we can use. And the newest one that I started using I would say about 8 months ago, I was the first one in North Texas to use this device. It's called a WEB, or a woven endo bridge. And what that does is it puts a little metal cage inside of the aneurysm. And so you use one device to change the flow dynamics in the aneurysm, and then the aneurysm clots off. And so it separates the aneurysm from the actual vessel. Once the aneurysm clots off, it heals, and then the vessel, we don't have to worry about the vessel rupturing anymore.
That's fascinating. And I know our listeners, we're getting in a little detail, but I think this is important. In this web technology, which you said is relatively new, and you started it 8 months ago, what would you say are the main benefits that come to the patient from this new technology?
Well, it's used, we have a few different devices to treat certain size and shaped aneurysms. This one specifically is used to treat a wider neck aneurysm, where if you were to put wires, or what we call coils, in the aneurysm, they would just fall out. And if they fall out of the aneurysm because the neck is too wide, then they clot off the vessel and the patient has a stroke. So what we're able to do, instead of having to take the patient to the operating room and open up their head, I'm able to deploy this device inside the aneurysm, and it will then occlude the aneurysm and seal it off from the parent vessel. And so, there's other devices that we use, but this is the newest one. And one of the major advantages with this one is you put one device in there instead of maybe 10 or 20 coils. So there's a cost savings, a time savings, a radiation saving, and so it's a pretty neat little device. It's not the magic wand. We don't have one device for every aneurysm, but it's just another tool in our chest that we have that we can, treat more aneurysms now than we could before because of this device.
That is so interesting. Let me ask you this. Are there other forms of patient care that are helping address aneurysms, whether it be diagnosis, treatment, support, other than the web?
Well, yeah, so the web is called woven endo bridge, and it's just one device. It's called an intrasaccular flow diverter, if you wanted to be technical. And what it does is it helps the blood flow be turbulent inside the aneurysm. There's another type of flow diverter called a pipeline, and that's like a stent, kind of like with your heart, but with a lot of metal. And that diverts the flow of the blood past the aneurysm. And then we have stents that we put in the vessels. We have stents to hold the coils in the aneurysms. So there's a bunch of different devices that we could use. Also at Presby, we now have a neurocritical care team to help manage these patients. That alleviates a significant burden for the neurosurgeon and helps provide cutting edge medical management after the procedure is done. So the one thing with aneurysms, if we don't catch them before they rupture, they do rupture and they can kill the patient. And so a lot of times the aneurysms we're treating have already ruptured, and we wind up using these devices to seal off the aneurysm, but then the patient's still in the hospital for a couple of weeks with the medical management.
Your technologies have changed so much. I know, like with the heart, for example, used to, if you wanted to go look inside, you had to basically open it up. Now you just send a wire up the leg. It's pretty easy. What are similar developments in your area?
Well, it's interesting. So cerebral angiography was developed in the early 1900s.
That's what I was talking about.
And so it's been around for a long time.
Right.
And it used to be the only way to see anything. You would have an X-ray and then an angiogram. And much older, a couple generations ago, the neurosurgeons would actually stick the needle directly in the neck into the carotid artery and do an injection.
Wow.
Yeah. So we're going back a long time.
Yeah.
And then they developed the CAT scan in the 70s, the MRI in the 80s, and then MR angiography and CT angiography have come about. So there's a lot of non-invasive imaging that we can use to screen patients or see what's going on in their brain. So a typical scenario is a patient goes to their doctor and they have headaches. So they get an MRI of their brain because they get a headache. And then there's a little abnormality that's seen on one of the sequences, and then they order an MRA, which is an MR angiogram. And then we're able to look at the blood vessels in the brain. But it's a very rudimentary picture. So what that does is that then leads the patient or the physician to refer the patient over to us, and then we look at that, and if it looks worrisome or large enough, then we would then perform the gold standard, which is the 100-year-old study, which is the cerebral angiogram, except our machines are much better now. So we have the newer technology. We're able actually to do 3D reconstructions and look at sub-millimeter vessels on the angiogram that you can't see on any of the other studies. So some of the blood vessels that we're looking at are half or a third of a millimeter in size. Some of the aneurysms I'm able actually to treat through the catheter are less than 2 millimeters.
Oh my!
So if you think about
put that in scale.
So
for
there's
us to
25 millimeters in an inch. So somewhere around a 16th of an inch, which is really, really tiny.
It's so
If
small.
you can imagine that, we're able to actually treat those without even opening up the patient's head anymore.
That is
So the
amazing.
technology it's come a long way, and the newer machines at Presby, I helped design the hybrid OR. It's an OR where I can do the angiography, I then spin the table, and then we can open up the head if we have to. So we're able to do a lot of combination procedures. I even use it for spine surgery sometime. And the machines are brand new. We're able to adjust the radiation dose so someone isn't exposed to too much radiation. Some of the older machines, the cardiologists, when they were working on the cardiac caths, would actually get skin necrosis and essentially burn the patient with the radiation.
Sure.
And that can happen in the head also. So they've made great strides, even just in the last 10 years, on the machines, on our ability to cut down on the dose that the patient is seeing. So we have the full gamut of technology over at Presby. It's wonderful.
This is Dr. Anthony Maioriello from Texas Health Presbyterian Hospital and UT Southwestern Medical Center, talking about some of the cutting-edge technologies in brain surgery. More on that when we come back on the human side of healthcare.
We're continuing our conversation on how you can empower yourself to have the best health possible in today's ever-changing healthcare environment. This is the human side of healthcare with DFW Hospital Council President and CEO Stephen Love and co-host Thomas Miller.
And welcome back. We're going to continue our conversation with Dr. Anthony Maioriello. He's with UT Southwestern Medical Center and the UT Southwestern Neurosurgery Practice at Texas Health Dallas. And Steve has a probing question for Dr. Maioriello.
Dr. Maioriello, just how serious of an operation is it when you cut someone's head open?
Well, do you ever hear the saying, it's not brain surgery? So, it's kind of that one, it's that one thing that everything else is measured against. So every operation we do has risks, and some of them are just more riskier than others. Whenever you're working on the blood vessels in the brain, it's much riskier.
Blood flow, right?
Yeah, as far as if you manipulate the vessel too much, it can go into spasm, the patient can have a stroke. The blood vessels in the brain are a little different than the rest of the body, and they don't have as much of a protective layer, and so they're much weaker. Some of them are so thin you can see through them, and you can see the blood flow through the actual vessel. So when you have an aneurysm, which is like if you were to imagine blowing a bubble with bubble gum, that's essentially what an aneurysm is on the side of a blood vessel. And so when you go to operate on those, it's pretty risky, especially if it's already ruptured. And then that's why, what we're able to do is actually go in from the inside of the blood vessel, never even open the patient's head, and treat that problem.
Many of us know people that have died in their 40s from aneurysms. Is there any way this can be prevented?
Well, yeah, so if you're lucky enough to see a physician before it actually ruptures, and they order some type of non-invasive imaging like an MRI or a CAT scan, sometimes you pick up on you can even see a 2 millimeter aneurysm on a CT angiogram. And then, the patient then would get referred to someone like me who would then decide, does this need to be treated or not? Not all aneurysms need to be treated right away. Some of the smaller ones can hold off depending on the location. And then if it does rupture, the key is getting to the hospital right away and then getting to a center like ours that can treat them in the highest acuity fashion.
You know, none of us want to be the worried well, but are there any early warning signs that we could pick up on telling us there's something going on?
Well, yeah, so unfortunately, aneurysms usually, if they're going to present themselves, they present themselves after a rupture. Someone has what's quote unquote the worst headache of their life. And it really, the way the patients describe it, it's kind of as if someone snuck up behind them and hit him in the back of the head with a 2x4. And they can usually tell you the exact minute of the day and exactly what they were doing when it happened because it's so devastating. And sometimes they go on to deteriorate into being comatose very quickly, and sometimes it takes a couple of hours. But usually they have the terrible headache, nausea, vomiting, changes in their vision, and then they rapidly deteriorate and herniate is what we call it, where the pressure in their brain is so high that they don't get any blood flow to their brain.
If there were to be an early sign, where would it show up?
If the aneurysm gets big enough to push on something. And so there is one of the aneurysms, posterior communicating artery aneurysm, is right next to a nerve that controls your eyeball. And when it pushes on that nerve, there could be some changes in the eye where the pupil gets bigger or the eye doesn't work the way it should. Sometimes patients are lucky and it presents like that. Sometimes they just have a headache or they have a bad headache and they call their doctor and they say go to the emergency room, and sometimes we see blood and sometimes we don't, and we catch it by chance. Sometimes patients have car accidents and they come in and we're looking at a CAT scan of their head for some other reason, and sure enough there's an aneurysm there. But as far as the ruptures go, they usually just present, boom, rupture. Family history is important. Smoking causes and increases the rupture rate also, and of course keeping your blood pressure in check.
You know, from your perspective, being an excellent neurosurgeon, can you explain to our listeners exactly what a stroke is?
So there's two different kinds of stroke. There's a hemorrhagic stroke where there's bleeding in the head, and then there's an ischemic stroke where you're not getting blood flow to a certain part of the brain. Okay, and so a hemorrhagic stroke, the aneurysm rupture falls under hemorrhagic stroke, which is subarachnoid hemorrhage, and
explain that. Yeah, let's go.
So what that is a hemorrhage at the base of the brain.
Okay.
So where all the blood vessels are.
Okay.
Okay, and about 85% of those hemorrhages are from aneurysm rupturing, and then there's parts of the brain that just rupture and just start bleeding all on their own. And sometimes that's from hypertension. Sometimes it's just from getting old, and the patient has something called amyloid angiopathy. We see a lot of that at Presby. And then from the ischemic side, you have a blood clot that forms in your heart, and it gets flicked off out of one of the ventricles in your heart and goes to your brain. And then it acts like a dam, and it plugs the...
That's a block, right?
Yeah, plugs the vessel. And that's called an ischemic stroke. And those are way more common than the hemorrhages. So
what vessel gets blocked?
Any of them.
Is it
It could be the carotid artery in the neck. It could be the carotid artery in the brain, anterior cerebral artery, middle cerebral artery, posterior cerebral artery. So there's any of the blood vessels in the brain can be occluded. And depending on what blood vessels occluded gives us some physical findings on what the patient can't do or et cetera. And so what we're able to do is then rush them into our angiography suite and do an angiogram and look at that occlusion, and then take a stent retriever or an aspiration catheter up to it and pull it out and reestablish blood flow. And if you do it quick enough, you're lucky enough to get the patient back to normal. I had a couple years ago, I think I was here about a year, and my daughter was going to Highland Park at the time, and the wrestling coach had a stroke at wrestling practice after school. And the students recognized there was something wrong with him right away, ran and got the nurse. The nurse called the ambulance. They got him over to us within 30 minutes, and we had him on the table within another 15 minutes. And I went up there and sucked out the clot, and he was perfectly fine an hour after the procedure. So every once in a while we get lucky like that.
I was going to say, and I'm sure it's case by case, person by person, but what's the time window?
So the sooner the better. I think every minute you lose about 2 million brain cells. I don't know. Every year they come out with a different number. But you rapidly lose brain tissue. And so we all have what's called collateral blood flow, meaning one territory of the brain is fed by mainly one vessel, but if that vessel shuts down, Mother Nature provides another route to get blood flow there. And sometimes the younger the patient, the better the collaterals. So we have better success with patients in their 60s that have strokes than patients who are in their 90s. So as you get older and they have atherosclerotic changes and the vessels get hardening of the arteries, you wind up having a difficult time with that collateralization, so you don't have as much time. But we have a special computer software at Presby where we have some perfusion imaging that we can do. And what that allows us to do is look at the actual blood flow to the brain and whether or not the brain tissue is actually salvageable. So we can actually measure whether or not the patient is getting enough blood flow, and if the blood flow is so poor that that area is going to be infarcted or not salvageable, or is it just slow blood flow and they're having a stroke, and if we reestablish the blood flow, are they going to get better? And so we're able to extend our time window now out to 24 hours. So we have patients who've had a stroke, in the morning, and they come in at night because they find, or just the opposite, where they wake up and they've had a stroke. And we don't know, did they have that stroke at 8 o'clock at night, right when they went to bed, or did it happen at 3 in the morning? But now with this perfusion imaging, we're able to get a better grasp on, are we able to help the patient? And if we can, then we'll take them right to the OR and do it immediately.
Thank you, Dr. Maioriello. What an important topic and some amazing science going on with brain aneurysms and strokes. Steve, we've got a busy September coming up around here.
We really do. We've got a great segment coming up with Janet St. James. We also are doing some work on an I'm Listening campaign dealing with removing the stigma associated with mental health treatment and suicide. And Labor Day's coming up. Please wear your mask.
All of that coming up in the weeks ahead here on the Human Side of Healthcare on 1080 KRLD
and radio.com.